So you have a patient with a lymphocyte count of 11, which is a significant increase. When you look down the microscope at ×10 objective, you notice there are more mononuclear cells than you should normally see. At higher magnification, those mononuclear cells are small lymphocytes that kind of all look alike. Also, there are several pink, purpley amorphous masses throughout the slide. What you are seeing is the classic initial presentation of chronic lymphocytic leukemia, or CLL. This is a disease of the B lymphocytes, or B cells, where one cellular clone proliferates, thus giving the name monoclonal B cell, should you see that in textbooks. Actually, this could be the initial presentation of another disease called Small Lymphocytic Lymphoma, or SLL. You might be saying,
Small Lymphocytic Lymphoma? I don't remember hearing that name in school.
Don't worry, this type of thing happens to all of us, and it's what makes our hematology journey fun. CLL and SLL are considered one disease entity, CLL/SLL, but with different clinical presentations. CLL is born in the bone marrow and presents in the peripheral blood as lymphocytosis. And SLL presents with lymphadenopathy, which is swelling of the lymph nodes. But CLL can have lymph node involvement, and SLL can have peripheral blood and bone marrow involvement. Throughout this video, I will talk predominantly about the CLL presentation, but you should know CLL and SLL are two sides of the same coin. So the typical CLL lymphocyte will be small and mature with a dense, clumped nucleus. The nucleus is said to have the appearance of a soccer or golf ball, or even cobblestones. Choose whatever comparison image works for you. This is a judgment-free zone. Usually there won't be nucleoli, and there will be scant cytoplasm. Likely there will also be pro-lymphocytes, but at less than 10% of the total WBC. Pro-lymphocytes have an abundant, pale staining cytoplasm and a large central prominent nucleus that will also have nucleoli. Now, those amorphous masses are termed smudge cells and are lymphocytes that get crushed during the smear preparation due to the fragility of the CLL lymphocyte. They are smear-making artifacts and therefore are not seen in the circulation of patients. Do not assume that if you see smudge cells that you are looking at CLL. They can be found in reactive lymphocytosis and other lymphoid neoplasms. In CLL patients, smudge cells should be included in the differential. Your institution will dictate how they are counted and the procedure employed. Some places will make a smear with an addition of a drop of albumin to prevent smudge cells from occurring, thus allowing the smear reader to confirm that the smudges are indeed lymphocytes, because other cells can smudge too. Some institutions will count the smudge cells as a separate cell type, while others will count them as lymphocytes, which in reality they are, just smushed. As always, follow your institution's policies, procedures, and guidelines. CLL is usually diagnosed in patients older than 50 years with a median age of 72 and a slight predominance in male patients. Patients usually present with lymphocytosis on the CBC with anemia, thrombocytopenia, and neutropenia. But you can also have patients who only have lymphocytosis. To diagnose CLL, there has to be a sustained absolute lymphocyte count greater than 5. Full diagnosis is usually made via flow cytometry. Typical CLL accounts for 80% of all cases, with atypical CLL seen in 20% of patients. Some subtypes of atypical CLL are CLL/PLL, where PLL stands for pro-lymphocytic leukemia, and a mixed type/atypical CLL. For CLL/PLL, pro-lymphocytes are greater than 10%, but less than 55% of the lymphocytes. With mixed type/atypical CLL, greater than 15% of the lymphocytes are large, atypical, or abnormal forms that have nuclear indentation or clefts. Atypical CLL may be identified at diagnosis or develop over time from typical CLL. Patients often have a prolonged survival with CLL. with those dying in the first few years of diagnosis often succumbing to unrelated disorders. Commonly, 50% of patients with CLL have a 5-year survival after diagnosis, while 30% of patients can expect survival of 10 years or more. Less than 10% of patients will transform to a B-cell neoplasm with a worse prognosis. Even though the pro-lymphocyte count will increase over time, transformation to pro-lymphocytic leukemia is rare. 2 to 8% of patients will transition to an aggressive, large B-cell lymphoma called Richter's transformation. Usually patients with early-stage CLL/SLL do not receive treatment but are monitored for progression. Treatment is usually for those who require symptom relief or have advanced disease. So you'll be seeing some of these patients for a long time, as you will be part of their monitoring process. To keep up your skills, check out this video here, where you can polish up your lymphocyte skills. Subscribe for future content. Thank you for watching. Until next time.